Good day, this is Nurse Marcia, and welcome to Part 2 of our Pediatrics NCLEX-RN Series, where we focus on gastrointestinal disorders. Today, we're diving into high-yield, previously asked, and all-time favorite questions from the NCLEX-RN and NGN exams. We'll cover critical pediatric GI topics like pyloric stenosis, intussusception, Hirschsprung disease, appendicitis, dehydration, and oral rehydration therapy. Let's get started. Question 1. Which finding is most commonly associated with pyloric stenosis in an infant? Bilious vomiting. B. Projectile non-bilious vomiting. C. Current jelly stools. D. Olive-shaped mass in the right upper quadrant. Correct answer, B. Projectile non-bilious vomiting. Rationale. Pyloric stenosis occurs due to hypertrophy of the pylorus muscle, leading to obstruction. The vomiting is forceful and non-bilious because the obstruction occurs proximal to the bile ducts. The olive-shaped mass is another classic finding but isn't as frequent. Question 2. Which findings are expected in a child with intussusception? Select all that apply. A. Sudden onset of abdominal pain. B. Sausage-shaped abdominal mass. C. Current jelly stools. D. High-pitched bowel sounds. Projectile vomiting. Correct answers A, B, C. Rationale. Intussusception is characterized by telescoping of one part of the intestine into another, causing acute abdominal pain, a palpable sausage-shaped mass, and current jelly stools, a mixture of blood and mucus. Vomiting occurs but is not projectile. Question 3. Hirschsprung disease results from the absence of which of the following in the distal colon, leading to failure to pass meconium within the first 48 hours of life? A. Goblet cells. B. Ganglion cells. C. Enterocytes. D. Smooth muscle cells. Correct answer, B. Ganglion cells. Rationale. Hirschsprung disease occurs due to the absence of ganglion cells in the distal colon, which disrupts normal peristalsis and leads to functional obstruction. This condition commonly presents with a delay in passing meconium within the first 48 hours of life. Goblet cells, enterocytes, and smooth muscle cells are not directly involved in this pathology. Question 4. A 10-year-old presents with right lower quadrant pain, fever, and nausea. Arrange the management steps for suspected appendicitis in the correct order. PO status. Administration of 4 fluids. Pain management. Imaging studies. Pendectomy. Correct order 1, 2, 4. 3. 5. Rationale. Suspected appendicitis management prioritizes stabilizing the patient and PO, fluids, and confirming the diagnosis imaging before surgery. Pain management is secondary to avoid masking symptoms. Question 5. True or false? Severe dehydration in infants is characterized by sunken fontanelles, lethargy, and a capillary refill time greater than 2 seconds. Answer true. Rationale. These are classic signs of severe dehydration. Infants have a higher surface area to body weight ratio, making them more susceptible to fluid losses. Question 6. Match the oral rehydration therapy, ORT guidelines to the condition. ORT. 50 milliliters per kilogram over 4 hours. C. Initiate 4 fluids. B. 100 milliliters per kilogram over 4 hours. Condition. Mild dehydration. Moderate dehydration. Severe dehydration. Correct matches. Mild dehydration A. Moderate dehydration C. Severe dehydration B. Rationale. ORT is effective for mild to moderate dehydration. Severe dehydration requires immediate 4 rehydration to restore intravascular volume. Question 7. Which of the following clinical findings is most indicative of pyloric stenosis? A. Current jelly stools. B. Projectile vomiting. C. Failure to pass meconium. D. Sausage-shaped abdominal mass. Correct answer, B. Projectile vomiting. Rationale. Pyloric stenosis is a condition where the pylorus muscle hypertrophies, leading to obstruction of gastric outflow. This results in projectile non-bilious vomiting, which is the hallmark sign of the condition. The vomiting occurs because the obstruction is located before the bile ducts, preventing bile from entering the vomit. Other findings such as current jelly stools, option A, and sausage-shaped abdominal mass are indicative of intussusception, a condition where part of the intestine telescopes into itself. Failure to pass meconium, option C, is characteristic of Hirschsprung disease, which is caused by the absence of ganglion cells in the distal colon. Differentiating between these hallmark signs is critical in pediatric assessments and management. Question 8. What physical exam finding is most indicative of appendicitis in a child? A. Murphy's sign. B. Rebound tenderness in the RLQ. C. Positive McBurney's sign. D. Abdominal distension. Correct answer: C. Positive McBurney's sign. Rationale: McBurney's point tenderness is highly indicative of appendicitis. Rebound tenderness may also be present but isn't as specific. Question 9. Which treatment is first line for intussusception in a stable child? A. For antibiotics. B. Surgery. C. Air or contrast enema. D. Laparoscopy. Correct answer: C. Air or contrast enema. Rationale: a therapeutic enema is both diagnostic and curative in most cases of intussusception. Question 10. True or false? Rectal biopsy is the gold standard for diagnosing Hirschsprung disease. Answer: true. Rationale: a rectal biopsy confirms the absence of ganglion cells, which is diagnostic for Hirschsprung disease. Question 11. Which findings support a diagnosis of pyloric stenosis? Select all that apply. A. Metabolic alkalosis. B. Weight gain. C. Olive-shaped abdominal mass. D. Dehydration. E. Green bile-stained vomit. Correct answers: A, C, D. Rationale: pyloric stenosis causes metabolic alkalosis due to vomiting, an olive-shaped mass, and dehydration from fluid losses. Weight loss is typical and vomit is non-bilious. Question 12 to 15. Case description: a 4-month-old male infant is brought to the emergency department by his parents. They report he has been irritable and crying inconsolably for the past 2 days. They also mention episodes of vomiting, lethargy, and a jelly-like stool seen this morning. On examination, the infant is mildly dehydrated with a capillary refill of 3 seconds. The abdomen appears distended, and a palpable sausage-shaped mass is noted in the right lower quadrant. Patient has a low-grade fever and imaging is ordered. Question 12. Which of the following findings is most consistent with intussusception? A. Non-bilious projectile vomiting. B. Current jelly stools and palpable abdominal mass. C. Green bile-stained vomit and abdominal rigidity. D. Ribbon-like stools and abdominal distension. Correct answer: B. Current jelly stools and palpable abdominal mass. Rationale: intussusception is characterized by telescoping of the intestine, leading to bowel obstruction. The hallmark signs are current jelly stools, blood and mucus, and a sausage-shaped mass. Projectile vomiting is typical of pyloric stenosis, and ribbon-like stools are seen in Hirschsprung disease. Question 13. Based on the infant's clinical presentation, classify the dehydration severity and match the findings. Dehydration severity: mild dehydration, moderate dehydration, severe dehydration. Findings: A. Capillary refill of 3 seconds, decreased urine output. B. Slightly dry mucous membranes. C. Lethargy, sunken fontanelles, absent tears. Correct matches: mild dehydration B, moderate dehydration A, severe dehydration C. Rationale: this case aligns with moderate dehydration as evidenced by a capillary refill of 3 seconds and decreased fluid intake/output. Recognizing severity helps guide rehydration strategies. Question 14. What is the diagnostic modality of choice for intussusception? A. Abdominal X-ray. B. Ultrasound. C. CT scan. D. Contrast enema. Correct answer: B. Ultrasound. Rationale: ultrasound is the preferred diagnostic tool for intussusception because it is non-invasive, widely available, and highly sensitive. The hallmark finding on ultrasound is the target sign or donut sign, which represents the telescoping of the intestines. While a contrast enema, option D, can be both diagnostic and therapeutic, it is not typically the first-line imaging tool. Abdominal X-rays, option A, may show signs of obstruction but lack specificity for intussusception. CT scans, option C, are not routinely used in pediatric patients due to radiation exposure and the availability of safer alternatives like ultrasound. Question 15. Arrange the appropriate steps in the management of intussusception in this patient. 1. 4 fluid resuscitation. 2 enema. 3 NPO status. For surgical intervention if enema fails. Correct order 3 1. 2 4. Rationale. Initial management includes stabilizing the patient by keeping them NPO and providing 4 fluids. An air enema is both diagnostic and therapeutic. Surgery is reserved for cases where non-surgical methods fail or complications occur. Question 16. True or false? An air enema is contraindicated in intussusception if there is suspected perforation. Answer true. Rationale. Air enemas are contraindicated in cases of bowel perforation because they increase the risk of further complications, including peritonitis. Clinical signs like abdominal rigidity and free air on imaging would suggest perforation. Question 17. Which electrolyte imbalance is most commonly seen in an infant with prolonged pyloric stenosis? A. Hyperkalemia and metabolic acidosis. B. Hypokalemia and metabolic alkalosis. C. Hypernatremia and metabolic alkalosis. D. Hypocalcemia and metabolic acidosis. Correct answer, B. Hypokalemia and metabolic alkalosis. Rationale. Pyloric stenosis leads to severe vomiting, resulting in the loss of gastric acid, HCl. This causes hypokalemia, potassium loss, and metabolic alkalosis due to hydrogen ion loss and volume depletion. Question 18. Which signs and symptoms are associated with Hirschsprung disease in an infant? Select all that apply. Bilious vomiting. B. Ribbon-like stools. C. Failure to pass meconium within the first 48 hours. D. Intermittent abdominal pain. E. Distended abdomen. Correct answers A, C, E. Rationale. Hirschsprung disease results in a lack of ganglion cells in the bowel, leading to obstruction. Common signs include bilious vomiting, delayed passage of meconium, and abdominal distension. Ribbon-like stools occur in chronic cases but are less common in infants. Question 19. Which interventions are appropriate for managing a ruptured appendicitis in a pediatric patient? Select all that apply. A. Keep the patient NPO. B. Administer broad-spectrum 4 antibiotics. C. Provide oral fluids immediately to prevent dehydration. D. Perform an appendectomy. E. Administer post-operative 4 fluids and analgesia. Correct answers A, B, D, E. Rationale. A. Keep the patient NPO. To prepare for surgical intervention and prevent aspiration, the patient must remain NPO. B. Administer broad-spectrum 4 antibiotics. Antibiotics are critical to managing infection caused by the rupture and preventing sepsis. D. Perform an appendectomy. Surgical intervention is necessary to remove the ruptured appendix and address contamination of the peritoneal cavity. E. Administer post-operative 4 fluids and analgesia. Post-operative care includes 4 fluids to maintain hydration and analgesics for pain management. Incorrect answer. C. Provide oral fluids immediately to prevent dehydration. Oral fluids are contraindicated before surgery. 4 fluids are preferred to manage hydration pre- and post-operatively. Question 20. Oral rehydration therapy, multiple choice. Question. What is the recommended sodium concentration for oral rehydration solutions in children with mild to moderate dehydration? A. 50 millimoles per liter. B. 75 millimoles per liter. C. 100 millimoles per liter. D. 125 millimoles per liter. Correct answer, B. 75 millimoles per liter. Rationale. The WHO and UNICEF guidelines recommend an ORS sodium concentration of 75 millimoles per liter for optimal rehydration in children with mild to moderate dehydration. This concentration maintains electrolyte balance and prevents exacerbation of fluid losses. Options A, C, and D do not align with current recommendations for ORS formulations. Question 21. Which clinical findings are consistent with severe dehydration in a pediatric patient? Select all that apply. A. Sunken eyes. B. Lethargy. C. Normal capillary refill time. D. Absence of tears. E. Slight thirst. Correct answers A, B, D. Rationale. A. Sunken eyes, a hallmark sign of severe dehydration due to fluid loss and reduced tissue turgor. B. Lethargy. Severe dehydration impairs perfusion, leading to lethargy and altered consciousness. D. Absence of tears, a critical indicator of fluid depletion in infants and young children. Incorrect answers. C. Normal capillary refill time. Severe dehydration often causes a delayed capillary refill, greater than 3 seconds, due to hypovolemia. E. Slight thirst. Thirst is more commonly associated with mild dehydration, not severe cases where compensatory mechanisms have diminished. Question 22. True or false? Air enema is the first-line treatment for both diagnostic and therapeutic purposes in intussusception. Answer true. Rationale. Air enemas are highly effective in reducing intussusception, particularly in stable patients without perforation. They are non-invasive and usually curative. Question 23. What is the most common initial symptom of appendicitis in children? A. Right lower quadrant pain. B. Diffuse periumbilical pain. C. High-grade fever. D. Severe vomiting. Correct answer B. Diffuse periumbilical pain. Rationale. Appendicitis initially presents as poorly localized pain around the umbilicus due to visceral innervation. Pain shifts to the RLQ McBurney's point as the parietal peritoneum becomes inflamed. Question 24. Which diagnostic test confirms the diagnosis of Hirschsprung disease? A. Abdominal X-ray. B. Contrast enema. C. Rectal biopsy. D. Ultrasound. Correct answer C. Rectal biopsy. Rationale. A rectal biopsy is the gold standard for diagnosing Hirschsprung disease. It reveals the absence of ganglion cells in the affected bowel segment. Contrast enema and imaging studies can suggest the condition but are not definitive. Question 25. Which interventions are appropriate for managing severe dehydration in a pediatric patient? Select all that apply. A. Administer a 20 milliliters per kilogram bolus of isotonic 4 fluids. B. Provide oral rehydration therapy at 50 milliliters per kilogram over 4 hours. C. Monitor urine output and electrolyte levels. D. Start maintenance 4 fluids after bolus therapy. E. Encourage oral fluids once the patient is stable. Correct answers A, C, D, E. Rationale. A. Administer a 20 milliliters per kilogram bolus of isotonic 4 fluids. Severe dehydration requires immediate restoration of intravascular volume through a rapid bolus of isotonic fluids, e.g. normal saline or lactated ringers. C. Monitor urine output and electrolyte levels. Monitoring is essential to evaluate the effectiveness of rehydration therapy and to detect complications such as electrolyte imbalances or renal impairment. D. Start maintenance 4 fluids after bolus therapy. Once the bolus stabilizes the patient, maintenance fluids are provided to prevent further dehydration and meet ongoing needs. E. Encourage oral fluids once the patient is stable. After stabilizing the child with 4 fluids, oral fluids are gradually reintroduced to continue rehydration and promote recovery. Incorrect answer. B. Provide oral rehydration therapy at 50 milliliters per kilogram over 4 hours. This is appropriate for mild dehydration, not severe dehydration, which requires 4 resuscitation due to compromised perfusion and fluid deficits. Thank you for joining me today. If you found this session helpful, don't forget to like, share, and subscribe to my channel for more NCLEX content and tips. Hit the bell icon to stay updated on all future uploads. And stay tuned for Part 3, where we'll cover pediatric infectious diseases. See you next time and good luck with your studies.